Good morning, sir.
Good morning.
Welcome to the 33rd episode of ISOT, due to be held in Kolkata from the 5th to 8th of October 2023. And welcome to the City of Joy. Now, for a little introduction, Dr. Peter Topham has been a consultant transplant nephrologist at the University Hospital of Leicester for the last 20 years. And he has trained in London, Boston, and in the USA and in Leicester, and was awarded the prestigious GlaxoSmithKline Fellowship on his return to the UK. During his time in Leicester, he has been the clinical lead in vasculitis and lupus services and the Leicester hypertension services. He has seen the doubling of renal transplant activity over the last 10 years and has also introduced the ABO incompatible transplant program. In addition to his clinical work, he has numerous educational roles managing the junior doctor training programs at all stages, from foundation to the specialty clinical training, and also in the academic training program. He has been the regional advisor for the Royal College of Physicians and has been an examiner for both MRCP and the specialty certificate examination. He is the co-editor of well-regarded Oxford text reference and in nephrology, which is now in its second edition. He has also been the primary investigator in a number of clinical studies in transplantation, vasculitis, lupus, and hypertension. He's currently undertaking a sabbatical as a consultant nephrologist in Bermuda, as well as providing clinical care to the CKD and dialysis population of Bermuda. He's leading a number of Ministry of Health projects to provide universal health coverage for patients with CKD, to establish an island-wide screening program and for the CKD, and to increase the provision of renal transplantation by promoting live kidney donation, enhancing financial coverage, and developing skills with other overseas centers. And he is also developing a project to investigate the genetic basis of the high prevalence of CKD in Bermuda. He will be returning to Leicester in 2025. Okay, with that grand introduction, sir, we can start today's interview. Of course, I had the privilege of working under you, and thank you for giving me the wonderful opportunity to train in the excellent Leicester, the renal department at Leicester. I had been very fortunate, of course, and most welcome to ISOT once again. So, sir, now coming to the topic, as we have discussed earlier, so you've been the lead in the different programs for treating vasculitis and SLE and hypertension. So, can you tell us something about your experiences in doing so?
Of course, yeah. So, as you kindly introduced, I moved back to Leicester having finished my training about just over 20 years ago, and took on a role as a clinical academic to start with, and kind of moved more to clinical work more recently. And I've been a transplant nephrologist for most of the time that I've been in Leicester. And as our services evolved, we then developed a more specific vasculitis and lupus service, and also then became involved in the hypertension service, which is recognized as a European clinical center of excellence. So my kind of predominant passion is transplantation. And over the last 10, 15 years, the size of the program has increased significantly for a number of different reasons, but largely that's down to an increase in the number of live donor transplants that we do, but also generally the number of transplants that are done in the UK at the moment has steadily increased over the last few years with the introduction of DCD transplantation. So as you indicated earlier, the program is almost doubled in size over the last few years. We introduced an ABO incompatible program a number of years ago, which has really helped a number of people get good quality transplants. We have a paired exchange program in the United Kingdom, which allows some people who are ABO incompatible to get transplanted, but that doesn't always work. And so having that available has helped a number of people get successfully transplanted. So that was a kind of an interesting process getting that set up in collaboration with my surgical colleagues. In terms of the vasculitis and lupus, we've got an excellent centre in collaboration with a number of other specialties, including rheumatologists, the respiratory physicians, and the immunology service. And we're involved in a number of clinical trials of novel treatments. And again, with the development of that service, we've significantly improved the quality of care that we provide to people with vasculitis and lupus in a kind of an environment where the treatment options available are evolving very, very quickly. And that's allowed us within that service to, provide kind of cutting edge treatments as they become available. So it's been a wonderful place to work, fantastic colleagues, and we provide a really good quality of clinical care to all of our patients, and it's been a privilege to work there. So currently I'm kind of in Bermuda. There's an opportunity to go and do something different, and so I've just stepped away from Leicester for 3 years, and I'll be heading back in 2025. But it's very different population of people here. There's a very, very high incidence and prevalence of kidney disease, a lot of end-stage kidney disease, way more than they should have, and so there is lots of opportunity and potential to do things whilst I'm here. So it's been a really exciting opportunity, which and it's a beautiful place to live. That's the other really good thing about it.
So about did you see any differences in the outcome in the ABO incompatible? If you make a comparative study between the ABO incompatible and the compatible patients, so did you see the differences in any outcome?
So far, the outcomes have been good. We've had no kidneys that have been lost through rejection. We've had, actually, in our population, we've had no episodes of antibody-mediated rejection after transplantation. We sadly lost one patient to kind of an intercurrent illness that was unrelated to the transplant itself. So far, the long-term outcomes are pretty comparable to the other live donor transplants that we've undertaken. We're pretty selective in terms of who we will accept for ABO incompatible transplantation in terms of the level of antibody titer that they have available, and we'll only transplant them if we can get the antibody titer under control beforehand. So I think that's helped us get away with really very good outcomes. So I think it's we use the kind of glycosorb technology, so the immunoadsorption. And it's a really, really nice technology, and we've had no issues in terms of people not tolerating the treatment, and in the vast majority of cases we've managed to get antibody titers to a level where transplantation can successfully go ahead. So it's been a really, really nice process.
Okay, sir. And since you are also a Center of Excellence for Vasculitis and SLE management, so what is the protocol that you're currently using for SLE and vasculitis more commonly? In SLE, are you using a mycophenolate, or are you using some other medicines? Are you using cyclophosphamide? So what are you using usually?
So in terms of vasculitis, for kind of organ-threatening disease, which is what we tend to see, we tend to obviously see people with renal vasculitis. We will typically give them steroids, and then we're kind of moving more towards rituximab rather than cyclophosphamide. So, like many things, as they get introduced in the United Kingdom, we have had rituximab available for a period of time. Initially, you were allowed to use it in relatively tight circumstances, but as experience increases and the cost of the drug becomes more acceptable, we're now using rituximab kind of more probably now than cyclophosphamide, simply because of its side effect profile being more beneficial. And then in terms of ongoing treatment, we either continue 6-monthly rituximab maintenance, or we will switch them to azathioprine, depending on kind of what antibody they have and what we think is their kind of risk of relapse. In terms of lupus, again, with class 4, it's either cyclophosphamide or mycophenolate. Again, we're moving more towards rituximab. And the other, evolution from that is the kind of use of obinutuzumab, kind of a more up-to-date anti-CD20 antibody. So we use that in selective cases. But again, as these things evolve, I'm sure they will become more used. Certainly since I've been in Bermuda, our links are with Boston. So patients with vasculitis and lupus tend to be supervised there as well. And it certainly appears that their first line anti-CD20 now is obinutuzumab rather than rituximab. So it's a very interesting difference in terms of practice. So that's been kind of interesting as well.
Yeah. Thank you for that. It's since you are going to talk about immunology and solid transplantation in India, whilst you're going to come to ISOT. So if you can tell us something about immunology of in solid transplantation in the multiple organ transplant.
Sure. So I got several briefs so I'm kind of doing a kind of a basic overview of transplant immunology in the pre-conference course. So I'll be really just reviewing the kind of basics of transplant immunology, the basis of kind of an alloreaction to a transplanted organ. And I've also been asked during that talk to give a perspective on transplantation in a multi-ethnic population. So in Leicester, where I'm based, we have a significant population of people primarily or originally from South Asia, so Pakistan and India, which presents certain challenges in terms of matching for transplant. So I'm going to give an overview of the issues around that in terms of different HLA profiles in different populations, different issues around the prevalence of chronic kidney disease and end-stage kidney disease, and also differences in terms of how likely people from different populations are to donate kidneys, and how that kind of comes together to potentially disadvantage people from minority ethnic populations. So I'm giving an overview of that, and then later on in the conference I'm talking about immunological challenges in combined solid organ transplantation. So I think the major issues there are around the different processes in which organs are allocated. Obviously in kidney transplantation, because we have dialysis and therefore rarely is the transplantation super urgent, we have the opportunity to ensure that there's as good a match as possible immunologically, whereas in heart, lung, liver transplantation, the clinical need for a transplant often means that those kind of immunological issues are of secondary interest. And so therefore there's a potential immunological challenge there in that you're not perhaps matching HLA as well as you would do. But the reality actually is that a combination of solid organ transplant seems to provide an immunological benefit. So I'm going to be talking about, the background to, the challenges of allocation of combined organs, also the kind of immunological issues that arise with combined transplantation, and actually the immunological benefit, particularly with liver transplantation. And then we're talking about how kind of organ allocation policies have had an impact on that as well. So it's kind of basically giving a broad overview of those kind of issues, really.
Thank you, sir. Thank you for that insightful talk, and thank you very much. We look forward to seeing you at Kolkata. So talking a little bit about Kolkata, it's located in the eastern part of India, and it's predominantly a Bengali population. And at this time of the year, we have the largest annual festival of Bengalis, that is Durga Puja. So
Right.
Yeah, so and the weather is the best at this time of the year. So I look forward to greeting you, and maybe we have these pujas in which all the communities participate, irrespective of whether of your social status or your religion background. Everyone participates, and it's more of a cultural interaction and social interaction. It's a community program actually, where the whole community comes together and celebrate. So, most welcome to Durga Puja as well, and look forward to seeing you in Kolkata.
I'm really looking forward to it. It'll be a wonderful experience, and as I say, I'm really, really looking forward to it.
Okay. Okay, sir. Thank you so much.
Thank you very much. Thank you.